This is Alyssa.
This is Caroline.
And this is Chelsea. Welcome to Med Surg Moments, the AMSN podcast.
This podcast is an engaging look at the lives of and surrounding medical surgical nurses.
We're proud medical surgical nurses, just like you, sharing our stories, insights, and experiences to support you in your nursing journey. We are sorry that Evie cannot join us today, but I am joined by Chelsea and Alyssa. What's going on in your world? What's new and exciting, ladies?
I have been accepted into Duke University's Adult Gerontological Acute Care Nurse Practitioner program.
Oh my gosh.
Yay! That's amazing.
Congratulations.
Thank you. I'm super pumped, super excited about that. Can't wait to meet my cohort and hit the ground running.
So what's your projected graduation date?
So I'm doing the program part-time. So I think it'll be 2024.
Great. That's exciting. Look at you doing stuff.
Always fun. Never stop learning. Never stop growing. That's
right.
Great.
I'm fulfilling my lifelong dream of lifelong learning.
There you go. I like that. Lifelong dream of lifelong learning. Yes. Okay.
I love that too.
Can you cite that statement and what edition of APA are you using? Yes, it's all going to come back to you now. You realize this.
Right.
Alyssa, what's going on in your neck of the woods?
Oh man. So I am in school right now. I've been working on my PhD for about a year now, and they're starting to talk to me about dissertation work. So that is literally what my focus has been on lately, is picking my topic, researching my problem. It was devastating. Actually, this week I had my first meeting with my instructors where I was able to throw ideas out on things that I'm interested in, and they're all patient focused, and I have to focus on academia. So all of my ideas of what problems do you want to solve? I'm so firmly implanted in nursing professional development and patient outcomes and quality improvement and all of that at work that I am struggling to find my problem that we can research and address in the academic world. So that is my current conundrum I'm working on.
It's a challenge, but it's one of those 2 a.m. moments. It'll come to you at the worst possible time where you want to write it down immediately so you don't forget that, you know?
Yes. I know, right? What about you, Caroline? What do you got going on?
So living vicariously through my children. My oldest is not my child, I'm not a child at all. So Jennifer's 26. But anyway, she's about to graduate with her second master's degree. She's now the proud owner of an MBA and a master's in healthcare administration. So coming to a C-suite near you.
That's great.
Yeah, we're very proud of her. And she's thrilled to be finally done. So she's working as a healthcare consultant right now, but I think ultimately would like to get into hospital administration. I'm saying, no, don't do it. But at least she's done with the education. So yeah, I'm very proud of her. That's the biggest event this week in my life. So yeah.
Well, we need good administrators. So if that's what she's into, let her get into it.
Indeed. Administrators are the ones that gather the data and share the data and tell us how good or bad we're doing, which leads us really nicely into this episode where we're going to talk a little bit about a very clinical situation and a growing problem, unfortunately, and that is how we can prevent CAUTIs, catheter-associated urinary tract infections, and CLABSIs, those central line-associated bloodstream infections, which back in the day we used to call septicemia. But it's a growing problem. It costs healthcare a lot of money. It gives way to a lot of extended time in the hospital and really is essentially preventable if we just think about what we're doing clinically or what order we're asking for. Do we really need that catheter? Do we really need that central line? Does the patient even need IV antibiotics? Can we give them PO? Everyone has got some form of order set or protocol when it comes to CLABSIs and CAUTIs. What do you guys do in your facilities? Do you have a big push on this initiative? Do you speak about the numbers daily, weekly, monthly?
Yeah, so at my facility, we have a pretty extensive way that we keep track of CAUTIs and CLABSI. So you can log into the hospital mainframe if your clinical staff put in your username and ID and your password and see at any given moment how many CLABSIs we've had in the hospital, how many CAUTIs, because it is a part of quality. It's a quality indicator for our hospital, as it is for most hospitals. So you can look at that at any time. And then we have something called a huddle board on our unit, and most units in the hospital do. And we keep track of falls, CAUTIs, CLABSIs. We can readily visualize percentage changes with our CAUTI and CLABSI numbers, mostly with every facility or hospital. We have an annual skills day where we go over how to care for someone with a central line or HD catheter or someone with a Foley catheter, and go over the protocols for that. This patient, if they're post-op, shouldn't have their Foley catheter for more than 24 hours. Let's take the Foley catheter out. If they're still having issues with urinary retention, if it's over 300, let's go ahead and do an in and out cath. The first thing we would do is give them more time. The second thing we would do is rescan them in 6 hours. And if it's still over 300, do an in and out cath. And then they get, I think it's 3 more tries with the in and out cath before we have to reinsert the Foley, because we obviously don't want our patients getting a UTI.
Do you have access to bladder scanners? Do you do a bladder scan before you do the straight cath?
Oh, absolutely. Our number is 300.
Yeah. With the scanner. Yeah.
Correct.
Okay.
Yeah.
Yeah. They're a handy little device if ever there was one. Okay. Sorry. Okay.
Oh, yeah. I gotta love those bladder scanners. So we have different rollouts. If they have a central line, then you know that you change the dressing every 7 days, that you make sure they have their chlorhexidine. Also with the Foley, make sure they have their chlorhexidine bath daily. And then with the Foley, after each episode of stool incontinence or stool occurrence, that they get Foley care with the chlorhexidine wipes and peri-care. So I'm pretty sure I'm speaking to the choir right now with our listeners. But yeah, we have all those rollouts. So you just have to be super diligent. This is always what I tell people. You have got to chart those chlorhexidine interventions, because if you don't chart it, that means it wasn't done. Same thing with line care. If you are accessing a PICC line, if you are making sure that you use those chlorhexidine swabs, et cetera, whatever, making sure that you change the cap. And I don't mean the green caps that go on the central line, the cap that is like where you insert and attach your flushes. You have to chart that, because if it's not charted, when we get audited, they're going to say, hey, this wasn't done for this patient. That's why they have the CLABSI. Another thing we have to look out for is making sure patients aren't tampering with their central lines, which can be difficult for our patients that have issues with narcotic misuse. Using that tamper-evident tape, making sure that they understand the significance of them accessing the lines themselves and putting themselves at risk for further medical complications. So that's another thing we have to look out for.
Yeah, it sounds like you guys have a pretty standard program on what we do with your protocols and your all of that. That's great.
To be one thing that across the country we're pretty consistent on. Alyssa, do you have anything similar or different than what Chelsea just mentioned?
So we do have an RN-driven Foley removal protocol as a part of our CAUTI bundle. So if the catheter is ordered under the RN removal order, then the nurse can assess that necessity every day for the catheter. If the catheter is still necessary, they have to document why. And we have the proscribed lists of how to justify maintaining an indwelling Foley catheter. If the patient does not meet that criteria as they're going through the RN-driven protocol, then they can remove it without speaking with the doctor, because the doctor has already determined when they place the order for the indwelling catheter that it can be removed without a conversation, right? When the patient's ready, when the nurse deems the patient ready, they can remove it. If we have it ordered as MD protocol, right? So the doctor says, no, don't remove it without having a conversation with me. The nurse will still go through that same criteria. And if the nurse feels like the patient no longer requires the catheter, then they will call and have that conversation with the physician. And we do have that in place in policy, protocol, whatever. The real question is how much is it being used in practice? I think that's really where we have an opportunity for improvement, because you get that patient that's post-op, you're supposed to remove it within that first 24 hours. And if your patient came to you at noon you're not going to remove it on your shift because you don't want to have to worry about pulling it and retention and bladder scans and straight caths. You'll just leave that. And then you pick up that patient for the night shift and you're like, I'm going to remove that at 6:59.
So if you would ever do that, you said that out loud, didn't you?
I know it. I know it. But that, let's be honest, that is the thought process. Like, why would I bother this patient all night long of trying to make them urinate when I could leave the Foley in until 6:59 or 6 o'clock or before the doctor's round, and then just make that a day shift problem.
It does make us think about our assessment skills as a nurse, and where one nurse would say, yes, let's get this out. Another one would say, no, let's just see if we can keep it for just a few more hours. This patient has a history of urinary retention or has a stage 3 or stage 4 pressure injury. That's actually one of the criteria that we can leave the catheter in, or for patients that need strict intake and output, of course. In our previous episode, we talked about our patients that are on palliative or hospice care. That would be another indication, obviously, for comfort care. These nurse-driven protocols obviously give us a certain amount of empowerment and decision-making, and oftentimes we can feel confident in our recommendation to a physician and follow through with that for sure.
Oh, absolutely. We just have to be careful not to look like the nurse who wants to leave the catheter in for convenience, which is unfortunately what happens. So that,
big no-no nowadays, big no-no. Yeah,
absolutely. Yeah. So that's something that we have in place. We have empowered our nurses to use it. Great nurses use it to their advantages, and their patients get great patient care. Other nurses may leave that catheter in a little bit longer than they should. Hopefully it still comes out and we don't have any issues, but statistically, the longer the catheter is in, the more likely the patient is to get an infection. So,
right. Yeah. I think we have to think about the purpose. Why were we even thinking about a catheter? And the purpose or the goal is just to prevent those UTIs and remove them in a timely fashion, and have that physician order, which must give a specific reason why it can stay there. Moving on to central lines, why are we so big on central lines? Well, of course, there's the convenience. Of course, it's much easier to administer large volume fluid, draw blood even. But those CLABSIs certainly put our patients at risk of increased morbidity and mortality. So assessment, once again, what does an infected site look like? A lot of facilities where I work now, we're fortunate to have a vascular access team, or a VAT team. And it's very much a hands-off for the floor nurses, but can be a great learning experience if something does look a little suspicious. And the VAT person, who's considered the expert, will say, okay, come along and look at this. Let's assess this together. What do you think? And the less hands you've got on this, obviously, the better in preventing the infection.
Does your vascular access team follow up after they place one? Because our team just does placement. And so our nurses do the maintenance and removal.
Yeah, ours are inserted by the VAT team, and then they're assessed every 24 hours. Not always on weekends, but again, a lot of education goes on so that the nurse knows the initial signs of an infection and gets an order to follow up with that if necessary for DC and of the line for sure, or at least doing a culture of the line to see if anything untoward is going on.
That's a really good idea. I'm like, that's an opportunity for improvement at my facility. I'll have to recommend that, because they do all of the insertion of central lines, but it's not in their workflow to then circle back and assess the lines while they're in place. But they are the experts, like you said. And so that's actually a really great opportunity where we could improve. So thanks for the recommend.
That's pretty cool, Caroline. Like Alyssa, we don't have that at our facility either. And Alyssa, it's interesting that you mentioned that you guys can remove central lines, because we cannot. The doctors have to remove the central lines at our facility. I've never removed a central line in my 5-year nursing career. So that's super, super interesting.
A nurse can pull a PICC line or a midline, but the physician has to remove the central line, I believe. I might be misspeaking there, but there's always an order needed to remove the central line. I know that. There's one for me to follow up on. I can't quite remember the protocol.
We do remove PICC lines and some central lines, ones that, like an EJ, like I've removed one of those before. but some central lines we don't remove. So I guess it does depend on the line. But since PICC lines are the ones that are most commonly used in our acute care setting, those are the ones that the floor nurses do remove.
Wow, that's super interesting. We don't do that at our hospital.
I often wonder what our listeners are looking for when they see the topics here. And I think one thing that we can say is that there is definitely consistency in the way that we manage central lines and urinary catheters. And we must always consider what we can do to stop inserting things into patients' bodies. And instead of an indwelling catheter, of course, there are the external devices which can work very well and definitely minimize the chance of an infection. And so there seems to be consistency. And so I would encourage anyone to be familiar with your protocols and policies in your facilities. Make sure you are focusing on basic hand hygiene, every patient, every time, and knowing signs and symptoms of infection aside from the redness and heat at the site, but a fever or an elevated white count or anything that indicates something is amiss and it's time to get this tube out of the patient's body.
The first thing I do is tell the patient not to touch anything. I know it's tempting, but don't touch your PICC line. Don't pull at your Foley catheter. If you are continent and we can get you to the toilet to have a bowel movement, that would be best so that stool doesn't go up inside your groin. And I definitely think mobility for my patients that have Foley catheters and don't have chronic retention problem, or they don't have a Foley to manage a chronic sacral wound, let's get you up. Let's get you to the bedside commode. And if they're not at the point where they can do that, then maybe a female external urinary catheter or maybe a condom catheter for our patients who have a penis. But even with those, we still have to do significant education. If you have a penis and have an external catheter, then we need to change that condom catheter every 24 hours. If you have a female external catheter, then that needs to be changed every 12 hours. So it just, even that has an education component to it. But I think, especially for my patients who are motivated to get better, who are in the position where they can be mobilized, you just encourage them and say, hey, let's get up to the chair. Oh, awesome. You got up to the chair. Let's see if we can get you to the bedside commode. And just keeping them motivated so they can get that Foley catheter out. And then just reiterating with our patients that have those central lines, PICC lines, HT catheters, do not touch your line, please.
Yeah, I think you're absolutely right, Chelsea. There's a certain amount of education that we want to give our patients before they have an infection like that. Hey, you have a PICC line, you need to not touch this. Hey, you have a Foley, you need to not play with this. And then there's the education that we give them after the infection has happened. Shucks, you've got this infection. This is how your plan of care has changed. Now we have to add all these antibiotics or however that looks, right? So that we can now treat the new infection. So I think making sure that you have your education given to your patient when they do have these invasive lines before an infection to help them prevent it, giving them those rationales. Please don't touch your PICC line. If you're touching your PICC line, you're introducing it to germs and blah, 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 right? You can get an infection. Please don't play with your indwelling catheter. If you move the catheter up and down the urethra, you're going to introduce bacteria into the urethra, right? That's the pre-education. And then, of course, we have to do post-education. Darn it, you got an infection and now we have to treat it.
A couple of tips with central lines, and hopefully it's fundamental, but 15 seconds seems like a lifetime, but it is so important to scrub that hub for 15 seconds and scrub it in a twisting motion, like you're juicing an orange. Very vigorous for 15 seconds, and then allowing another 30 seconds minimum for that port to dry. That minute can be the difference between an infection or not. The other thing to remind people about is flushing, using that pulsating technique when you are flushing, implementing 10 brief boluses of 1 ml at a time, interrupted by a short pause to keep any bacteria that might be there flushed out of the system. And something I learned, it's confession time, something I didn't realize for many years was that a lot of us tend to date and initial, as we should, directly on the semi-permeable dressing, the opsite dressing. Big no-no. Yeah, Alyssa's looking at me like, I missed that somewhere along the way.
Yeah, you should have a sticker.
You could, you could either puncture the dressing, or who knows what's in those Sharpies that could permeate into the skin. So big no-no, especially for our new nurses out there. Remember the flushing, remember the scrubbing, and remember no writing on the dressing. Use the little label that actually comes in the kit.
No, you're absolutely right. We definitely want to make sure we're using those stickers instead of writing straight onto that Tegaderm or whatever you're using as you're dressing. Hopefully it's some sort of Tegaderm. For those exact reasons, right? We don't want to puncture the wound. We don't want to have anything going through the dressing and getting into the patient's skin. Those are all really great tips. The other thing that I would add in for tips for nursing is really assessing, do I need this line? If a patient is getting intermittent antibiotics every 4 to 6 hours, and that's the only thing they're getting, do they need a PICC line? I understand a PICC line can be helpful, especially if you have someone who's a difficult stick, all of those kinds of things. But ultimately, a PICC line is a direct access to the patient's bloodstream. And so the risk for infection is great. And so we definitely need to do that risk benefit analysis with using a PICC line, and then recognizing when the PICC line is no longer valid. When do you not need it anymore? They were on a continuous antibiotic before, now they're not. Should we be switching the access? And we definitely need to be looking at it from a patient care perspective rather than a nursing convenience perspective. And I'm totally guilty of having that convenience. Oh my gosh, they're going to pull the PICC line. That sucks. Now I have to start an IV. But ultimately, that decision was what the right decision was for the patient. And it's the same with an indwelling catheter. Great. Now I have to go pull the catheter, and it's going to be more work for us to get the patient out of bed and get them into the bathroom. But that's actually what's best for the patient. You can get the patient out of bed and get them into the bathroom. That's like part of PT. That's how I talked my patients into getting out of bed. I'm like, hey, man, we're going to count this toward PT. Let's go to the bathroom. We really need to be making those decisions from the perspective of what's going to help the patient reach the ultimate goal of being able to go home and be better, rather than what's going to make my life a little bit easier for the next 12 hours.
I agree, Alyssa. I want to flip the switch here. When do we need to talk about getting that Foley catheter in or getting that central line access in? I know I have patients, we're more like an MU unit these days, those high acuity patients where we legitimately cannot get access on them. We need to throw something in and get them off to the ICU or wherever they would be more appropriate. Or those patients that have that chronic urinary retention where it's getting to the point where we're starting to see blood because we're traumatizing them from having to know them so frequently or throughout our shifts. So let's go ahead and have that conversation about getting that Foley catheter in. We oftentimes have to consult urology, sometimes for patients who need a different French size. Maybe they're a 20 French or a 22 French and have some weird anatomy, and we practically cannot get a Foley in. Okay, we need to start initiating that conversation with the primary medical team and with urology, and then with the central line access. Okay, we need to, obviously, if they're this sick, we need to call a medical emergency team and see if they can go ahead and slip something in and then get them off to the ICU. So definitely, we need to advocate for our patients getting those things out, but then also we need to advocate for them getting them in. So.
I think that's such a great point, Chelsea. And you're absolutely right. There are situations where we're trying to follow the protocol and it's do a straight cath on your patient so many times. And you end up with a doctor that never does order that indwelling catheter. And the patient ends up being straight cath 8 times over 24 hours. And there's now urethral trauma. That is absolutely a time when you should be advocating for your patient. Look, man, we've straight cathed the patient multiple times. We're developing urethral trauma. We need to do something different. You absolutely bring up an amazing point on the flip side of the coin. Another amazing part of advocating for your patient. And same thing with the central line. There are times, right? Your patient becomes so sick that you have to run so many fluids and antibiotics and medications to manage their issue. And the access you have isn't adequate. Oh, and they're going to throw in blood, and how many other things can I throw in there that you have to have a dedicated line for? So you're absolutely right. And we can't forget, we can't assume that if we're not pulling out the catheters or central lines or whatever, that we are being lazy. There are reasons why we leave them in, and there are reasons that we advocate for them. So hopefully that is not being misconstrued with the information we're giving today. We just want to make sure we're advocating in the right direction for ultimate patient care.
Absolutely. That's what it's all about. Patient safety and good outcomes for sure.
Some other tips is just continue to do education with nurses, especially new nurses. Make sure they understand the protocols. In our middle hallway, in our old huddle area, we have all of the protocols for spines, Foleys. Tell them, go ahead and grab that. Let's go step by step. It's okay. And also another tip is grabbing a second person. Well, we have to do that at our facility. We have to have a second person for Foley catheter insertion. For central line dressing chains, we do not have to have a second person. When you have a patient that's confused, I take a second person so they can hold their arm. Even if they aren't confused, I have someone else that can be sterile and pass me more of what I need. So just some tips, always ask for help and definitely use your teamwork.
I love that you said take your checklist. That's something that we love to encourage in my facility is please take your checklist, take a buddy, and they can walk you through it. And they're like, oh, before that step, you need to do this step and make sure that you're doing everything the way that you should, especially in a procedure like inserting a catheter. It is very step 1, step 2, step 3, and all the way down to like 20 steps. So making sure that you're doing everything in the order that you're supposed to, making sure you're not breaking your sterile field. Everyone listen to Chelsea. Take your checklist, take your buddy and make sure that you're doing it.
Yeah, call it a checklist, call it an order set, but nurses follow directions very well, and following those steps means consistency, and consistency means standardization, and that means ultimate safety and better patient care. A good 30-minute clinical discussion, I think. Hopefully we've given you, our listeners, some tips and some memory joggers about managing catheters, managing central lines, with the bottom line being assess and remove them as quickly as you possibly can.
We look forward to connecting with you all on our next episode of Med Surg Moments, the AMSN podcast. In the meantime, we want to hear from you. Send us your questions, topic ideas, and feedback via our official Med Surg Moments email address, amsnpod@amsn.org. That's amsnpod@amsn.org. I'd also like to remind you to become a member or renew your membership at www.amsn.org. You'll receive lots of cool benefits and perks, such as discounted pricing on annual convention and continuing education.
We encourage you to help us spread the word and subscribe to the Med Surg Moments podcast via your smartphone podcast app to receive notifications of future episodes. Please be sure to leave us a review, tell us how we're doing, and recommend Med Surg Moments wherever you get your podcasts to help us reach even more listeners. I also invite you to join the conversation by sharing your ideas and questions on AMSN's Facebook, Instagram, LinkedIn, or Twitter pages. And don't forget to add #MedSurgMoments to your post. Simply enter AMSN in the search field on any of these social media platforms to connect with us.
The content within the Med Surg Moments podcast represent the views, thoughts, and opinions of the co-hosts and may not necessarily reflect the views, thoughts, and opinions of the Academy of Medical Surgical Nurses. Until next time, I'm Chelsea.
I'm Alyssa.
And I'm Caroline. And always remember, Med Surg Moments is a moment in our lives, a moment in our Med Surg careers that make a huge difference.